Okay, so very good afternoon, everybody. And on behalf of Indian Academy of Neurology Movement Disorder Subsection, we welcome for this Movement Disorder Subsection PG program myself and Dr. Ravi Yadav, who is the convener of the subsection. And we thank the President and the Secretary of IN for giving us an opportunity to allow our PG and young faculty members to do the presentation and learn from cases. To have the further proceeding, I invite Dr. Ravi Yadav, who is the convener of the subsection. Dr. Ravi.
Yeah, thank you, Dr. Sanjay. And in extension to what Dr. Sanjay said, this program was envisaged almost 1 year before. And we have done one program in the last year. The main purpose, which was actually planned with when Dr. Achal Srivastav and Dr. Sanjay were there, and I was there, and Dr. Pal, we had thought that the main purpose is to generate interest among the young PGs in the area of movement disorders. And there is no other way than to discuss the cases which are difficult and which to understand the phenomenology. So now the whole plan was to involve the medical colleges of different states and the young faculty who are interested in this area, and provide them with the opportunity to get involved in Indian Academy of Neurology and promote the subject of movement disorders. So now the first faculty who is very keen and very much interested, I would invite Dr. Shweta Pandey, who is additional professor of neurology at King George's Medical University, Department of Neurology, and she is a Hewitt Gold Medalist, and which is very prestigious medal in MBBS in KGMC. And so she will be now taking over and discuss with her PGs about some of the interesting cases in movement disorders. So Dr. Shweta, you can take over and initiate the discussions.
Good evening, everyone. Thank you, sir, for giving us this opportunity. And we have two cases from King George's Medical University. And first case will be discussed by Dr. Kirti Raj. And I request Dr. Kirti to share his screen.
Yes, ma'am. Audible, ma'am.
Yes.
Let's start.
Yes, you're audible. Please go ahead.
Good evening, respected teacher. My name is Dr. Kirtiraj, myself a senior resident from KGMC. Hereby, I will be discussing case of 22-year-old male who is a right-handed, born of non-consanguineous marriage with normal birth and developmental history, no known comorbidities, and family history was negative for any neurological disorder or any medical condition. He presented to us with episodic abnormal involuntary movement since 11 years and episodic visual disturbances since 5 years. This episodic abnormal involuntary movement in the form of twisting of right upper limb and lower limb, lasting for about 4 to 5 minutes, and these were preceded by abnormal sensation in the epigastric region, fearfulness, and palpitation. There were no definite triggers or any precipitating factors, and episode 1 to 3 episodes per month or for 3 years. And these episodes were controlled with phenytoin, which he took for 3 years and was symptom free for those 3 years. For the last 5 years, there is a change in seminology with visual disturbances in the form of episodic blurring of vision in both eyes, along with multiple colored halos that is to persist in both eye opening and closing, and inability to gauge the distance and the size of object without impaired awareness. There was premonitory symptoms like anxiety and palpitation. These were occasionally triggered with loud noise. It was not associated with any headache, automatism, or any clonic movement. These episodes used to last for 3 to 5 minutes with a frequency ranging from 1 to 2 episodes per week to 2 to 3 episodes per day. Gradually, for last 10 months, he developed episode of abnormal twisting of all four limbs which fall. Initially noticed on the way to school, he used to go by walking and hearing loud noises. These episodes used to last for 10 to 20 minutes with 4 to 5 episodes per month. And these were also preceded by abnormal epigastric sensation, anxiety, fearfulness, and palpitations. And he used to get up and walk back to home or school himself after these episodes. For last 3 months, there is increasing severity with involvement of neck, tongue, even speaking difficulty, and it is to be associated with pain and tremulousness during the episode. And there is increasing duration. Now the episode used to last for 30 minutes to hours with a frequency of 4 to 5 episodes per day. And these episodes even triggered by the low amplitude noises, movement, sometimes by event touches. There is history of asymmetrical tremulousness of both lower limb and intermittent involuntary posturing of hand and feet in between these above episodes. Over the course of illness, he didn't have any history of decreased sensorium, uprolling of eyeball, or frothing from mouth, or urinary or fecal incontinence, or any postictal confusion. Now I will be showing the video of depicting the above clinical manifestation, and videos are obtained after informed consent from the patient and his bystander.
Dr. Kirti.
Yes,
Hello,
ma'am.
Dr. Kirti.
Yes, ma'am.
Can you just summarize your complaint so that everyone knows what these are, because these were very long. So just summarize in 1 or 2 lines what the patient is having, what are the complaints, and
Yes.
what you're going to show.
Ma'am, he is a 22-year-old male. He presented with episodic abnormal involuntary movement in the form of tonic posturing of right upper limb, lower limb, initially involving the right side. Then over the period, it gradually progressed to involve the whole of the body, which were variable in duration and variable in severity as. With intact awareness, without any history of decreased sensorium, uprolling of eye, or any frothing, or any incontinence, or any posterior confusion. This episode used to happen in the awake time.
Okay.
There was one more complaint with episodic blurring of vision with intact awareness, and he could not appreciate, he could see the multiple colored halos during the episode. However, there was no loss of consciousness, any headache associated with those episodes.
So were these visual episodes associated with these motor movements too?
Ma'am, most of the time, like initially it was rarely associated with movement disorder, abnormal movement. Now, recently, since last 3 months, most of the visual abnormalities are associated with abnormal movement.
Okay. So you are discussing about these episodic events, some motor movements, some visual complaints, and that is progressive. That is obvious with your complaint. So what do you want to show in your, okay.
Is showing some abnormal movement, which are described in the phenomenon, which is told in the clinical feature. Here, our patient is lying supine at rest. There is intermittent posturing of distal part of the lower limb with irregular jerky movement of both lower limb, predominantly involving the distal. In sitting position, even with outstretched arm, the ongoing tremulousness movement of both lower limb is continuous. On wing beating position, the tremulousness is ongoing, along with mild tonic posturing of upper limb. On asking the patient to walk, we could see there is posturing of a distal part of the left arm, predominantly involving the hand, and even the right arm. These were the videos which were recorded after provocating with loud noises. Here there is continuous tremulousness movement which is ongoing, and with loud noise we could appreciate there was agonist phase with tonic posturing, distal part. Here after once again stimulation with loud noise, he is developing tonic posturing of both hands, even with neck, and there is a jaw opening, and he is responding to our oral commands. He is telling like he could not speak even with maximal effort, and he could not appreciate any, he could not able to see. And these events were recorded in the inpatient after provocation. Here he developed tonic posturing of both upper limb and even the neck, Even there is a jaw opening, and this event was lasted for around 40 to 50 minutes.
So can you analyze what these movements are? Some of these movements, they are present at rest with no worsening on activity, no change in any posture. So, and some of these episodes, they are episodic. So can you analyze it? What these movements are?
There are there is episodic tonic posturing, that is predominantly involving the distal lower limb, predominantly feet, with irregular jerky tremulousness of both lower limbs at the rest, and these are provoked with even loud noises. Predominantly tonic posturing with tremor.
What kind of tremor is this?
It is irregular and jerky, so I would like to prefer for dystonic tremor. And involving the part which is affected by the dystony.
If you combine the history and the noise, the sound I could not hear, but at that time opistotonic posturing was also occurring.
Sir. There was involvement tonic spasm of trunk also. It was generalized distribution. Both all four limb, trunk, including the neck, and even there was a jaw opening.
You can proceed. Yeah.
Go ahead.
Coming to symptom analysis, he presented with episodic tonic posturing, initially localized to right side. Over the course, it progressed to involve the generalized distribution, which was precipitated by multiple triggering factors with movement, loud noise, and even touch, and with intact awareness during the episode. There is variability in duration, initially for few minutes, now it is progressed up to hours, and it used to happen only during the awake time. So first symptom I would like to think of more of like a paroxysmal movement, predominantly paroxysmal dyskinesia. Even in tonic posturing with intact awareness can also happen in focal epilepsy, predominantly involving the frontal lobe. So I would like to keep those also one of the probable etiology for that person. The other complaint was visual disturbances, which was episodic with intact awareness, where he could see multiple colored halos with inability to gauge the distance. That can be focal aware seizure with localization to localized to occipital lobe.
So what do you think these episodic visual symptoms in which he could not gauge the distance, depth, from where they are arising?
That could be originated from the bilateral occipital lobe.
Is he having any headache?
No, it was not associated with any headache or any altered sensorium, and there is no tonic gaze deviation during these episodes.
Any motor deficits during the episodes?
Now, since last 3 months, above symptoms was associated with even with the motor abnormal movement. Otherwise, there was no deficit associated with this.
So after resolution of these episodes, he used to walk normally. He could walk. He could do all his activities intermittently.
Yes, ma'am.
What was his interictal period like? How was it?
Now, since last 3 months, there was intermittent posturing and tremor. Otherwise, he could perform his all activities.
Okay.
So, I just want to know that these episodes of twisting and with the sound were there.
Yes.
On top of that, you are saying that at the baseline also there were the tremors which were continuing throughout, isn't it?
Yes, sir. Since, that was recent onset since last 3 months.
Because the phenomenology of the episodic event is different as compared to at rest when he was lying down. There we saw rhythmic to and fro movements of the distal part, both in the legs and in the resting position, it was there. But the episode which was triggered by the loud noise, that was completely different. And there we saw it, the whole, the generalized involuntary movement and dystonic posturing. But while walking, he was walking with the right hand in a twisted type of position in the flexed posture. So did you further? Okay, now you proceed. Yeah.
So I would like to consider it can be a focal epilepsy or a abnormal movement disorder or a combination of movement disorder with focal epilepsy. Coming to axis classification concerning dystonia, axis 1 based on the clinical characteristic, onset was childhood onset.
So, Kirti, what are the factors which are favoring that this is a movement disorder or this is a seizure or epileptic syndrome? Can you tell us?
In my case, the factors favoring the movement disorder are that these movements are predominantly dystonic movement with a tremor, which was present both ictally and interictally, and there was intact awareness, and these used to happen only during the awake time. There was no post-ictal phenomena or any tonic-clonic movement or any tongue bite. Favoring the seizure, these are episodic events. There was a presence of aura, and initially he had a good response to anti-seizure medication. Coming to axis classification, axis 1 based on the clinical characteristic, the onset was childhood onset. Distribution, although variable, severe format generalized distribution. It is a progressive and paroxysmal invariable. And it was dystonia with focal seizure, associated focal. Etiology, I would like to consider idiopathic and acquired both as a probability.
So, Kirti, so can you tell us what are the episodic, paroxysmal, neurological, recurrent events which we come across in our day-to-day practice, which we see? One is paroxysmal dyskinesia, you told, one is epilepsy, different epilepsy syndromes. What else can it be? I mean, what other episodic?
Others like headache symptoms like migraine, trigeminal neuralgia, trigeminal cephalgic autonomyalgia can also be paroxysmal. And PNS, psychogenic non-epileptiform seizures.
So do you think this is a psychogenic non-epileptic attacks? So how do you differentiate from a non-epileptic attacks?
During the episode or during the interictal period, those movements were not distract. There was no distractibility and there was no entrainability was also not there. As well as there was no functional symptom associated with the patient. There was no stressors also found.
Okay. So there was no variability, there was no distractibility, you said?
Yes.
Okay. Go ahead.
Coming to examination, there was no KF ring, Shostak sign and Cruzy
We are-
sign.
So just to interrupt, so we are dealing with a patient who has a border zone of epilepsy and movement disorder. So these are the very important group of disorders which actually can come to a neurologist as well as to epileptologist, and we have to understand in depth what are the causes. Okay, we can proceed.
General examination, there was no KF ring, and even though there was no neurocutaneous marker, Shostak sign and Cruzy sign were positive. Higher mental function was normal. Speech was normal during the interictal period. Cranial nerve examination, including fundus, was normal. Motor and sensory findings was normal. DTR was normal during interictal period, and there was no positive cerebellar sign. So examination, we added Shostak sign and Cruzy sign. Other were negative.
So what these signs they tell us?
There was a sign of neuromuscular hyperexcitability, probably because of hypocalcemia.
Why did you look for these signs? And there is a patient for 11 years history of episodic abnormal movements with some kind of rest, tremor, and dystonic posturing with interictal normal behavior, normal activities. So why did you check? What was in your mind that you check for a routinely? We don't check for a, I mean, Chausius or Chostic. Why did you check for it? What was in your mind?
Based on history, we had a one of diagnosis of paroxysmal dyskinesia also. So we wanted to rule out secondary cause because there is a variability in duration, severity, as well as.
So whenever there is a patient with episodic this abnormal movements which we are discussing, maybe epilepsy or abnormal movements, maybe a combination of both. So we tend to rule out a secondary cause every time because that is treatable one. Though these paroxysmal dyskinesias or they are also well responsive to antiepileptic drugs, still we need to completely treat those patients so that they don't need treatment actually. So it's symptomatic one so that they are symptom free. So that is why we want to rule out a secondary cause whenever these paroxysmal events are there. So we just want to rule out any structural thing. We want to rule out the metabolic abnormalities, which are often associated with these paroxysmal events or paroxysmal dyskinesias. So that is why you check. One of the commonest metabolic abnormality, that's it, calcium related abnormality, the metabolism abnormalities may be related to this paroxysmal dyskinesia. That is why you checked for it. Okay.
Yes.
Dr. Sanjay sir, do you want to say anything?
I was just basically off the meeting for some time. But I was just looking at the video. What is the phenomenology of the movement?
Can you
Dr.
show me first?
Yes, sir. There was, during the interictal period, there was tonic posturing predominantly involved in the distal part of the lower limb, associated with irregular jerky tremulousness, predominantly involved in the distal part.
No, it was tremor or it was a jerky type of movements.
Myoclonus. Was it myoclonus? The question is that one of the
Yes.
audience
So
also
was it
put
tremor or was it myoclonus?
It was irregular, but it was not so jerky, sir. It was looking like tremor. It was to and fro acceleratory, which was irregular in
Let's show it again. Dr. Kirti.
Yes. Can we see one more time?
So just show it and again tell what it
first
is.
one. Yes, you show this one.
yes, there is
So it is more like a dystonic tremor basically.
Correct.
These
So
are
there is a normal posturing, but
associated.
the movement is definitely rhythmic in nature. So it's a dystonic tremors. Okay, please go ahead. Please go ahead.
Go to the same slide. where
Yes,
you-
yes.
provisional diagnosis. It's a childhood onset progressive paroxysmal dystonia with focal seizure, paroxysmal dyskinesia with focal seizure. So my provisional diagnosis will be paroxysmal dyskinesia. I would like to consider both idiopathic and acquired at the etiology.
So why do you want to say this focal seizure associated with this dystonia? What is in favor of this focal seizure? Why do you want to say it?
One focal seizure can present with intact awareness. So our patient had a visual focal aware, like he had a visual disturbances which was episodic with intact awareness. So I would like to consider the focal epilepsy of occipital origin in that. That's it.
So he had a visual complaint which is related to some sort of cortical involvement, you want to say?
Yes, ma'am.
Because he was having issues with depth perception, he was having some colored halos and this thing. That is why you want to keep this focal epilepsy with dystonia.
Focal epilepsy with dystonia.
Can there be this aura in dystonia also? Can we get
Yes,
it?
ma'am. We can get one sensory aura in dystonia also.
Sir, Sanjay sir. So these auras, especially visual auras, were there in this patient. That is what is the main problem, whether it is related to epilepsy, focal epilepsy, aura, visual, or it's related to just movement. That is
The
one.
patient never had any focal seizure, no?
So these were the episodes which were occurring with sound, loud sound. So he
Yes,
used
so-
to have generalized dystonic posturing, though he remained aware throughout, but he would respond, but he would not speak. And with when he recovers, he would complain that he was not able to see, he was seeing some objects, he was not having the depth perception, the size perception of objects that was there in most of the episodes, and some episodes were without it.
No, so if the person has any movements which is like following the sound, there can be two possibility. One, it can be a subcortical myoclonus, or the patient may have a maybe hyperexplexia that is startle. So startle and subcortical myoclonus both are seen in many metabolic disorders. But what is the relevance in your case, that I don't know. But auditory myoclonus is very, very typical of subcortical myoclonus and hyperaplexia, that is startle syndrome.
So sound sensitivity can be seen with subcortical lesions, and
Yes,
with movement
yes.
disorders also we can see some sound sensitivity.
Yes, but here there is clear-cut dystonia, and the primary movement is dystonic tremor.
Yes, sir.
Dystonia with dystonic tremor, and you were saying there is some auditory stimulus leading to this type of movement.
Yes.
So we need to see what is the relevance of that.
I feel that in the initial part, historically there was a history that with phenytoin it completely resolved for few years.
Yes.
So that possibility I do not know that he's still or anti-epileptic, but a possibility of coexisting focal occipital, origin related seizure is there, because that kind of colored halos and what he's seeing cannot originate from anywhere else in the visual pathway. I feel so.
Yeah, that may be a possibility, definitely.
But these movements also, they tend to respond actually, sir, with anti-epileptics.
Yes,
I mean,
definitely. The
this
paroxysmal
movement disorders
movement,
also, they tend to
paroxysmal movement, they tend to improve with anti-epileptic drugs.
Okay, we can proceed because we have one more.
Yes, please.
Coming to investigation, his complete hemogram, including general blood pressure, was normal. Liver function and kidney function test was normal. Thyroid profile was normal. Slit lamp examination was negative for KF ring. His serum ionic calcium was decreased in the range of 2.68 mg per dl with elevated serum phosphorus 5.14 mg per dl. Serum magnesium was normal but in the lower limit of the normal range. Serum albumin was normal. His serum parathyroid hormone was raised in the range of 1674, and vitamin D3, serum ceruloplasmin, CSF glucose, and iron profile study was normal. He recorded EEG during ictal and interictal period. During both periods, there was no any epileptiform discharge. Coming to MRI brain, T1 and T2 image was normal, and there was showing blooming artifact in bilateral lobus pallidus region in GREC.
Did we have CT scan?
CT scan was normal. There was
Oh.
no hypertension.
So tell us the diagnosis. What is your diagnosis?
My diagnosis will be paroxysmal dyskinesia, secondary to pseudo-hypoparathyroidism, secondary to calcemia because of pseudo-hypoparathyroidism. Still, I would want to rule out idiopathic causes. Because there is longer duration of history with early onset age. I would like to rule out one idiopathic genetic cause.
You don't have any differential because for pseudo hypopara the 11 years duration calcification in CT would come up. I don't know. You must have reviewed this. I hope you will cover that.
So that is why genetic diagnosis has also been kept. Maybe this is a combination of both. Maybe what kind of genetic abnormality can we get in this, Dr. Kirti?
According to seminology, it is not fitting into any PKD, PNKD variant, but we are like proline rich transfer protein tool can both have both PKD, PKND, but since it doesn't fit into anything, it can be genetically heterogeneous.
So learning point is here is, sir, it is not fitting into any paroxysmal kinesiogenic or non-kinesiogenic kind of dyskinesias which we see in genetic ones. So the episodes are very longer, episodes are multiple times a day, there is visual aura associated with it, there is loud noise, so much of sound sensitivity associated with it. And though he has responded to anti-epileptics initially, so we don't know what actually exactly it is related to this, or maybe some other genetic things such as ATP1A2 or which is related with these paroxysmal abnormal movements and epilepsy and other syndromes. So that can be the possibility. So we also did CSF glucose in this patient, because every time when these paroxysmal events are there, so even in adults or children, though the glue deficiency present in infancy only, but later also in later ages also we can find it, the paroxysmal episodes with developmental delay, with some cognitive issues and this thing movements. So we did CSF glucose also, that was negative. And because of this affordability issues, we could not get this genetic testing done. So by history,
After managing the calcium and other things, he did not improve.
he is improving, sir. The episodes has reduced, and the intensity of the duration and the intensity of episodes has also come down, though he is also on carbamazepine.
And Dr. Shweta, how do these paroxysmal disorders, how do they evolve? Like, is it like episodic ataxias where those episodes will transform into continuous symptom complexes? Because for him, even in the interim
Rest.
period, he's having those abnormalities, right?
Those
So-
were the abnormal things which were there with him.
Okay.
Though the episodes were episodic, intellectually he was completely normal. Despite the fact that he was normal, he was having rest, abnormal posturing, on rest, in sleeping. I mean, in lying down, not in sleeping. With sleep, it
No,
was
so that
appearing.
is actually, it is a
And then-
complicated.
Yes, it's a complicated one. Maybe some genetic cause, sir. Maybe it's just secondary, so that we'll see in follow-up only whether he improves completely on drugs, and this rest tremors and posturing also they improve.
Definitely.
In that case only we can tell that what
Yeah.
it is, because it has definitely evolved. Normally the
Mhm.
paroxysmal dyskinesias don't evolve as
Don't
such.
evolve.
They
Exactly.
have, I mean, maybe the spectrum may change. Maybe initially they have epilepsy, then they develop movement disorders, and maybe
Mhm.
the combination of both. But those remain almost in similar pattern. It is not following a pattern. It was initially very infrequent, that frequency increased, then at rest also. And
Yes.
that is why we kept the possibility of secondary. That is why we inquire for every secondary possibility, except for genetics. We did all the things, including CSF glucose, so that we can know whether any secondary thing is there or not.
So we can, the main learning points briefly, Shweta, you can tell, then we can proceed to the.
Dr. Kitty?
Learning point from my case are, when assessing the episodic neurological symptoms, it is important to consider the possibility of movement disorder.
Yes, this was one, because every time when the episodic neurological episodes are there, we are much involved in epilepsy, seizures, we are treating them like epilepsy. So they are on multiple drugs, these movements don't respond, and then we keep on adding. And actually we need a diagnosis. Maybe they respond to treatment, but for 11 years, the diagnosis is still not settled, though he is responding. But we need a diagnosis. So we need a spectrum. We need to identify whether it is a movement disorder or epilepsy or a combination of disorder. Yes. Second point.
Distinguishing between the seizure and paroxysmal dyskinesia can pose challenges.
Yes, like
As
in
in
the
our
case, it's very challenging. EEG is normal, MRI is normal, intellectually he is normal, despite he is having so severe dystonia that he is listless, but he responds. That is one thing. And it never happened during sleep. That is one thing. Only 2 points which are there, which suggest that probably the epilepsy, either it is a focal one, EEG is not showing anything, or it's a movement disorder.
and even differentiating between the primary dyskinesia and secondary dyskinesia can even be difficult most of the time.
So it is not that we say that it is a primary or genetic one, or it's just secondary one, because we repeatedly get low calcium, high parathyroid. We repeated twice actually, because we have doubt in mind that this is a true report or this is something else. So we repeated it, but repeatedly he had this hypocalcemia and hyperparathyroidism, which was the parathyroid levels were high. So it's difficult, sir. In this case, we cannot say whether it is primary or secondary. Yes.
And it is essentially to thoroughly investigate and look for treatable secondary causes in any movement disorder, even when it has persisted for extended period.
Yes, sir. That was the last thing. So we need to rule out all the secondary causes in all cases of movement disorder. That is the lesson from this case.
So I think we should do the genetic study, because many primary familial brain calcification, lot of genes are implicated, like SLC20A2, PDGFRB, XPR1, and many other genes. So maybe it is one of the gene-associated primary brain calcification leading to this type of manifestation, because SLC20A, we have seen some patient who present like a combination of seizure and paroxysmal dystonia with brain calcification. So the phenomenology is interesting, but we need to do the genetic testing to know the exact cause in this
The
patient.
counseling him, sir, as soon as we get the genetics, will update you.
Yes, yes.
We
Thank you,
can
sir.
move on to the next case. Yeah. So in the meantime, it's very important. I think these are the puzzling cases. So, so Dr. Saurabh will be presenting the next case.
I think we should present Dr. Saurabh. Are you here?
Am I able to share my screen?
No, you just share your screen. You are audible, but your screen is not visible.
Just 1 minute.
I think the issue has resolved with you.
Yes, ma'am. Now it is visible.
No,
Is it
it's
now?
not here.
Wait,
Ravi sir, it's visible?
No, it is not visible.
Not.
Dr. Saurabh, you will have to go to Zoom. Are you able to see Dr. Pandey, Dr. Yadav, and Dr. Shweta Pandey also? Or Dr.
Yes,
Yadav?
ma'am. Yes, ma'am. Yes,
Yeah, so
ma'am.
click the green share screen button
Yes, ma'am.
and then select your PowerPoint. One of the options on your screen will be PowerPoint.
Yes, ma'am. I'm selecting it, but I'm not able to.
No. First
Yeah, you have to-
open the PowerPoint on your desktop,
Yes, sir. I have opened it on my desktop.
and then
Yeah.
click the share button, and then you will see that.
So once you click that, you have to click the share button, the blue share button.
Yes, ma'am. I'm clicking it, but I'm not able to
It
just.
must be minimized somewhere. Maybe you can.
You first open it on your desktop and see it is open.
Sir, it is open. My PPT is open on my desktop, but
Okay. Dr. Shweta Pandey, what we can do is that
Yes.
you can go ahead with the next speaker.
I can do. Ma'am, I can do my presentation through Kirti, sir. I think we can proceed with the other presentation. I will present my case at last. Okay, ma'am?
Okay, Dr. Dinkar, can we do it?
Yeah, we can do it. We can do it.
So we go
Thank
ahead
you,
with
sir.
another case, and maybe in last we'll discuss the case of Dr. Saurabh.
I'll
Sure,
talk to
sure.
Dr.
So, Dr. Dinkar, please continue from
Dr.
here.
Dinkar is a professor of neurology at RML Institute and Lucknow, and he has done his fellowship from Canada in movement disorders. He will be moderating these two cases, next following cases. Dr. Dinkar.
Yeah, thank you, sir. At the outset, I'd like to thank the IN committee, Dr. Sanjay and Dr. Ravi for giving us this opportunity. So we have two cases, and with the time constraints, we'll keep it short. And the first one is a treatable hyperkinetic movement disorder. Dr. Rohit,
Yes.
it's over to you, and just be short and concise. Discuss the phenomenology, try to explain what you are seeing, and then we'll proceed further, right?
Okay, sir. Okay,
Yeah.
sir. Yeah, good evening, everyone. So I'm here to discuss about a rare treatable hyperkinetic movement disorder. So this was a 15-year-old girl who presented to us with complaints of tremulousness of left lower lip since 4 months duration and weakness of right lower limb followed by right upper limb of 3 months duration. The tremulousness was subacute in onset and was progressive, was first noted on standing for prolonged periods during school hours 4 months back. The diffuse lower limb tremulousness, there was diffuse lower limb tremulousness with sudden intermittent current-like jerks felt predominantly in the left lower limb. However, there was no knee buckle or fall. These movements used to subside during sleep and occasionally noticed on sitting as well. These were progressive in nature such that the shock-like jerks gradually involved the truncal region and upper limbs as well over the next 2 months. There was no obvious change noted in the severity of the abnormal movements per se, but they became more generalized. The weakness was subacute in onset and progressive. She noticed difficulty in wearing slippers and holding them in her feet initially, more on the right side. over the next few weeks, she also developed grip weakness with her right hand. And there were no features suggestive of proximal weakness in both upper limb or lower limb. There were no history of seizures, behavioral changes, cognitive dysfunction, language or speech abnormalities, cranial nerve involvement, bladder bowel or sensory symptoms, or fever prior to these symptoms. There was no history of measles in the past as well. So just to summarize the history, there were present, the patient had a 15-year-old girl with subacute onset of abnormal jerky movements in left lower limb. I would first like to consider the possibility of myoclonus most likely. The points in favor are the jerkiness character of the description of the movement was like jerky in nature, electric current like jerks she felt. And
just to interrupt, the video you should show, and then I think you can.
Okay. Rohit, let's go to the video then.
Okay, sir.
Then you come back to this.
Okay.
So this is the video of the patient. Okay. So this is first. The extraocular movements assessment was normal. Should I directly go to the movement?
No.
Complete video.
The circuits and pursuits were also normal.
Rohit, what is happening to the trunk?
On a background, yes, sir. On a background of these extraocular movement, if you just note again, sorry, there is an irregular rhythm, small amplitude, intermediate speed, continuous truncal side-to-side movements, which looks like it is partially suppressible and is present at rest. This looks like possibly a truncal tremor, but the irregular rhythm of that is pointing against it. It could be more likely a resting truncal myoclonus, I think so.
Okay, keep going with the video.
Next in line, yes, he's just elaborating her symptoms. On doing a next, when we did the forward arm holding, if you'll just note, there is irregular small amplitude, fast, non-suppressive kind of intermittent jerky movements of the fingers, which were not present at rest. I'll just go back once again, just to do the hyperkinetic movements of the finger. These look like they are possibly a postural action myoclonus, or they could be even the truncal myoclonus, which is trickling down to the upper limb, because they were very subtle and we had to look very closely to observe that. We can note mild dyssynergia and dysmetria on these finger nose and finger chase test. But I think these movements were actually a part of the overlying myoclonic movement that were happening in the fingers.
Okay, so Rohit, if you can pause it here for 1 second.
Yes, sir. Yes, sir.
So you are saying that this is probably a truncal myoclonus, which is overflowing, so to say, to involve the hands.
Yes,
now, is it a multifocal myoclonus, or you think it is a part of the truncal, or we can say a spinal or a propriospinal myoclonus, which is affecting the multiple segments of the multiple spinal segments? So how do you say it is a multifocal myoclonus versus a propriospinal or a segmental myoclonus?
It can be a multifocal myoclonus, sir, because right now at this point we can't say exactly, because all we can see is a distal movement of the finger. So that constitutes one segment. And apart from that, there is truncal movement. So at least two non-contiguous segments are there. So I think we can call it as a multifocal myoclonus.
Okay. And also here, I'd like to say on visual examination, there is asynchrony between the upper limb movement. If you can start playing the video now. Yeah. So when we are checking for ataxia here. When she's doing the finger chase test, Rohit, you can see that the synchrony between the trunk and the upper limb movement, especially on the right side during the finger chase, is interfered with. So doesn't look like it is a single source generator. Probably it is a multifocality in her myoclonia.
Yes, sir. Even the source
generator. Can we see her walking?
Yes, sir. Just next in line, I'll show.
I think you just move the video a little forward and
Yeah. And voice was involved by any chance?
No, sir. No, the voice was not involved. Actually, I have muted the video, but if you want, I can just.
No.
The
Proceed.
voice is normal, sir. Okay, just a minute. I think my screen got interrupted, I think somehow.
Yeah, that video you were showing that.
I think Saurabh PPT came in between.
Yes, sir. Yes, sir.
Yeah, sir, I got it, sir.
Yeah,
Okay, please play the video forward.
Yeah.
Yes. Please go ahead. Play the video.
Yes, sir. The power assessment was grossly normal, only slight distal weakness of hand grip and toe grip was present. And the reflexes were brisk. Planters were on the left side was extensor, the right side it was flexor. Gait assessment, actually there are two videos.
First, we'll see the pre-treatment one when she stands.
Okay.
So just
now, if I'll just describe her, she's able to get up without support, and she has acquired a wide base stand. However, on standing, we notice irregular medium amplitude, fast, jerky movements of left lower limb, which looks more on proximal and trunk. Possibly a propiospinal myoclonus. I'll just go to one more video. Just 1 minute. Yeah, this one. You will just notice on this one. Yeah. This. So we can note there is a irregular jerky component of, and it looks more on the left side, and it is more proximal. And even on the truncal side, there is the jerky component has increased as it was while sitting. The jerky component has definitely increased. And the step length and step width are actually varying as per the tremulousness. So however, the cadence and was normal.
Okay.
So Rohit, what do you feel out of this? What phenomenology do you feel it is now?
Sir, actually, we have on the basis of all these features, what I would like to say, we have multiple types of myoclonus here. Like even the history and the examination findings looks like it was initially a focal myoclonus, which later on became segmental. And there were presence of all rest myoclonus, postural myoclonus, as well as action myoclonus. And these myoclonus had no reflex provocation. These were all spontaneous myoclonus, and they had no reflex elicited either by auditory stimuli or by touch. They had no reflex provocation. And so based on these findings, I think the source generators are probably, it can be cortical, it cannot be explained from a single finding.
Okay.
So we were expecting that it's some illness. This is due to a cortical or a subcortical brainstem that is non-segmental, or a propiospinal myoclonus. All three possibilities could be entertained from these videos.
Okay.
And the etiology,
but Dr. Rohit, for a cortical or subcortical myoclonus, a prominent feature of these myocloni are to involve the cranial musculature also.
Yes,
so
sir.
cranial musculature, proximal muscle groups should be involved as well. So
Yes,
this is something that is going against your source of generation being cortical or subcortical. However, your patient also had right hemiparesis, right?
Yes, sir. Yes,
we
sir.
cannot appreciate it now during our examination.
Yes, sir.
So now can you fit it somewhere if she has a right upper limb, lower limb weakness with?
Yes, sir. Out of these three, I would still like to keep cortical above both of them.
Okay.
Because in spinal, even in spinal, we have no place.
You are not audible, Rohit.
Dr. Rohit.
I would like to tell here that when you describe myoclonus, there is no point describing it segmental or multifocal something, because myoclonus by definition is a multifocal movement disorder. But you need to describe whether it's focal or it's generalized. So if it is a focal, it's more likely to be your cortical pathology. If it is sensitive to some stimulus, or maybe it is generalized, it is more likely to be a subcortical pathology. So here looks more like a generalized myoclonus.
Okay.
And if you say propriospinal myoclonus, it's a different, very different entity. Because propriospinal myoclonus, there should be involvement of the axial muscles. And when you say propriospinal myoclonus, in the modern literature, it is considered it's functional. But it doesn't look like functional in this patient. It's more like a generalized myoclonus.
Okay.
And I was not very sure about the eye movements, what the patient eye movement had, because you were examining, but I was not able to see any movement in that. Any eye movement finding?
No, sir. Sir, extraocular movements, saccades, and pursuits all were normal, sir.
Okay, so the person, the girl has a generalized myoclonus.
Yes, sir.
It has a hyperreflexia, that was very clear.
Yes, sir.
So she has a pyramidal involvement.
And
Yes.
sir, right-sided weakness as well, sir.
Yes, she has a right-sided weakness,
Yes, sir.
and she has subcortical myoclonus.
Okay.
Yes, sir.
So we need to have a differential diagnosis based on these three findings.
Yes.
Yes, sir.
So don't bring propriospinal myoclonus here, because everything will get diluted. Otherwise, we'll start thinking in a different direction.
Yes. Okay.
Also, my additional comments are that since there was wide-based, gait also, and
Yes,
also in
yes.
the resting position,
Yes,
she was
yes.
having tremulousness.
Yes.
Whereas cerebellar involvement also you would,
Yeah,
or
definitely. I
circuit
fully agree.
would like to bring in, because that will bring another axis. So myoclonus with pyramidal with cerebellar also would be one thing which I would think, because in the resting sitting position also she was having like a titubatory type of thing, which I'm not sure whether in the standing position also she was not stable. So that is one of my observation.
I also wanted
And etiology wise, the moment it's a very short illness, a possibility of maybe edem, or maybe a very MOG-like illness, MOG-related demyelination. So this type of possibility in a pediatric age group, and if it is there is some eye movement, I'm not sure about the eye movement, because whatever I could see, the eye movement was looking normal.
Yes.
So if the eye movement is normal, if the eye movement is abnormal and there is a myoclonus, then obsoclonus myoclonus also becomes a possibility. But if it is just a myoclonus involving the trunk, limb, so we will just consider the myoclonus, pyramidal weakness, hyperreflexia, and some cerebellar signs. So it's a multi-axial involvement. And in this age, considering the short duration illness, a possibility of maybe MOG associated demyelination or maybe some infective pathology. So these are the possibilities.
Yes, sir.
So yes, with this kind of axial predominant involvement, spinocerebellar tract has to be, we should think of this spinocerebellar involvement along with, because she is ataxic, she could not, stand.
Yeah.
It is, the base is wide and the titubation is there. So maybe not just myoclonus, it's a combination of
So
the.
can we see the investigation? We should move
Can
forward.
proceed. Yes, we have half an hour left. We have two cases and one short.
So we
talks.
did the routine blood investigations. LFTs, RFTs were normal. Thyroid functions, viral markers, ceruloplasmin were also normal. Calcium, PTH, and lactate levels were also normal. EEG showed normal background activity, and there were no KF rings. Tumor markers were negative. Cervical spine screening was also negative, was normal. However, MRI brain showed T1 hypo intensities, which were hyper in deep bilateral, predominantly deep white matter hyperintensities on T2 flare, which showed peripheral ring enhancement, and which were also restricting peripherally only. Only the margins were restricting peripherally on DWI, and these showed low ADC values as well. Schwann imaging was almost normal. So, although this open ring enhancement actually made us to believe that, although the open ring enhancement made us to think of two DDs actually, that if it is a tumefactive demyelination or a Schilder's variant of MS, and because of the subacute onset, also we thought that, and a young female. But although the peripheral ring enhancement and the open ring was facing towards the white matter part, and which is unlikely in a tumefactive demyelination. Generally, the tumefactive demyelination open ring faces towards the gray matter or towards the basal ganglia, which was not in this case. But however, we proceeded with a diagnosis of tumefactive demyelination over the Childers variant. The LPCSF findings were normal, and we ruled out other secondary DDs of tumefactive demyelination. We sent for serum OCBs. Serum NMO was also negative. We even planned for a biopsy of the lesion, but the attendants were unwilling for the same. So we gave the patient 5 days of injectable MPS and oral steroids thereafter. However, the symptoms persisted and we counseled the patient for plasmapheresis, but they were unwilling for the same. So we went ahead with IVIG 2 gram and we discharged on oral steroids. On follow-up, we already saw the videos of prior to IVIG therapy. This is how the patient looks 4 months after follow-up of treatment. I'll directly skip on to the gait disorder, gait part. If you could note, even on sitting position, her truncal instability or tremulousness has significantly decreased at baseline, and there is still a slight jerkiness which is still present on the left lower limb, but it is significantly less than as prior to the steroid therapy.
The spasticity has set in, or
no, sir. Spasticity was present only on the right half of the body, which has declined only from baseline, sir.
okay, since we are running short of time, we can quickly go on to the next case.
Okay.
Thank you.
So just points to
Yes.
remember.
Okay, so just a few learning points here were, again, it is the phenomenology. As Dr. Sanjay said, if we actually thought of bringing in propriospinal myoclonus here because everything was confined to trunks, upper limbs, and lower limbs. But then the MRI took us to the cranium. And as Sir said, propriospinal myoclonus mostly has a functional origin. So we'll just keep it down, and probably it was a subcortical myoclonus. Imaging and movement disorders, whenever we are considering any movement disorder, it is better to get an imaging done. Do not think that it is idiopathic or primary. Before we get the genetic workup, rule out most of the secondary causes, and in all probability, we'll get a diagnosis as a secondary myoclonic disorder, secondary movement disorder. And then white matter lesions, typically it is said that myoclonus should be linked to a gray matter or a cerebral pathology, but it is not so. Even demyelinating disorders, MS in itself is associated with so many movement disorders. So even these should be considered in our list of differential diagnosis. So because we are running short of time, Dr. Ravi, can I go to the next case now?
Go ahead. Yes.
Dr. Shweta, is Dr. Saurabh ready, or?
I think you finish
Yes,
first.
sir.
You finish both the
Dinkar,
cases.
you finish
Okay.
first and then Saurabh can
Okay,
come.
Dr. Meet. Dr. Meet, can you hear?
Hello. Yeah, yes. Am I audible?
Yes, yes, yes. Just share your screen and start, Meet.
Hello.
Meet, we are seeing your name, but the slides are not coming.
Is my screen visible?
No, not it. Nothing is visible. It's only your name that is coming on a black background.
You share the screen.
Share screen button, Dr. Meet. You need to come to Zoom. Are you able to see all the panelists?
Yes, ma'am.
Yeah, so just hover on one of the photographs. The video. Yeah. Now your screen is visible.
But Zoom screen is visible.
No, you first open the PowerPoint and then it will come.
This PowerPoint is open, sir. Just 1 minute.
Okay.
I'm stopping your share screen, Dr. Meet. You just
Yes,
select
ma'am.
the first option, which is the desktop. Don't select any other screen. The first option of desktop you select.
Yes, ma'am.
Yeah, and then share your screen.
Yeah, okay.
Okay.
So now is my screen visible?
Yes, Meet, you can start here.
Yes, you can.
Good evening, respected teachers. So I am going to present a case of chorea in pregnancy. So this patient was a 24-year-old lady, and she was a primary gravida of low socioeconomic status from Balia district, UP. She came to neurology OPD at 18 weeks of gestation with headache of 3 months duration and abnormal movements of right lower limb and upper limb of 1 month duration. Headache was diffuse, holocranial, not associated with vomiting, photophobia or phonophobia, episodic and mild in intensity, and would subside on its own without any medication, with no raised intracranial pressure features. The abnormal involuntary movements started in the right hand, initially at action, and then progressively increased to be present at rest. Since 1 month, abnormal movements were noticed with slow movements of fingers. The abnormal movements were non-jerky, continuous, started distally, non-violent, and used to disappear in sleep. Since 2 weeks, similar movements were observed in lower limb. Along with that, abnormal stiffness and twisting in right hand and foot was observed, and this was more on trying to hold things with right hand or gripping slippers in right foot. So patient was on regular ANC checkup, and previous USG about 2 weeks back was normal. She was on medication with iron and folic acid supplementation with no any other history of drug intake. There was no history of fever, sore throat or arthralgias or rashes. There was no prior history of rheumatic fever, no prior history of jaundice or abdominal distension, no comorbidities, no other comorbidities or behavioral or psychiatric issues, no family history of any neurological illnesses. So based on my history, I would like to summarize that a 24-year-old primary gravida of 18 weeks gestation presented with episodic headache of 3 months duration with abnormal, involuntary, random, non-violent, non-jerky movements of right upper limb and right lower limb, along with abnormal stiffness and posturing movement of right hand and foot.
You can show the videos.
Meet, you can directly come to the videos
Okay, sir.
and explain on videos what all you are seeing, the phenomenology.
So as we can see in the video, we are checking now for extraocular movements. So the extraocular movements appeared to be normal, and the pursuits and saccades were also normal.
Keep describing what you're seeing, Meet.
As we can see, the speech of the patient is normal, and during examination, patient was having abnormal, involuntary, random, graceful, non-rhythmic, slow, ill-sustained, and non-patterned, medium amplitude, non-suppressible movements in right upper limb and lower limb, which were flowing from one body part to another, and which were present during rest as well as on action. And on action, abnormal involuntary stiffness and twisting movements and posturing of right hand could be seen, along with with the flexion and fanning of fingers. And now, as we were doing the finger nose test in this patient, we could see that there was abnormal stiffness and fanning of fingers, along with posturing of right upper limb.
So, Dr. Meet, what do you make out of these movements now?
So, sir, there were two types of movements that we could appreciate in this patient. The first movement was patient was having abnormal involuntary, random, and graceful type of movement which were non-rhythmic slow, ill-sustained, continual, non-patterned, medium amplitude, and non-suppressible movements flowing from one body part to another. And so I would like to keep the possibility of hemichoria, right hemichoria in this patient. Along with that, on action, we could appreciate abnormal involuntary stiffness and twisting type of movement, leading to positioning of right hand, and which was ill sustained. And so there was a possibility of dystonic posturing as well. So combining both, I would like to keep possibility of hemichoria, hemidystonia in this patient. Right-sided hemichoria, hemidystonia.
And why were these movements not ethitotic or ballistic? Because they are hemi.
Yes, sir.
And distal.
Sir, actually, ballistic movement would be of greater amplitude and violent type of movements.
Okay.
But the movements in this patient were of medium amplitude and non-violent type of movements. And ballistic movement would be more in proximal in distribution, as opposed to in this patient where the movements were distal as well as proximal.
Okay.
Dr. Meet, so when there is abnormal posturing of hand,
Yes,
right
ma'am.
hand you said, no? So
Yes,
when
ma'am.
dystonic posturing, do you want to say these movements as chorea, or you want to say it like dystonic tremor? So how to differentiate? I mean, I say this is dystonia with dystonic tremor, or this is a chorea with dystonia, which you wanted to say. So how to differentiate it?
Ma'am, actually, in dystonic tremors, the tremors would be like.
You just run the video also while you are discussing. Again, once.
Yes, sir.
And go on telling what madam has asked. Yeah.
You can just show the, yeah.
Yes, ma'am. Ma'am, tremors would be rhythmic and oscillatory. The character of tremor is rhythmic and oscillatory. But
so dystonic tremor also is rhythmic and oscillatory?
Yes, ma'am. Along with that, there will be features of dystonia as well. Patient will be having stiffness and posturing, and superimposed on that, he will be having rhythmic and oscillatory movements. But here the movements are sustained and ill sustained. Sorry, movements here are ill sustained, and on action we can see that the movements are ill sustained and twisting and posturing of left hand is present.
So chorea is often quasi-purposive. What does that mean? I mean, what does that mean? Quasi-purposive. Can you see in this patient?
Yes, ma'am.
So there is dystonic posturing. You can appreciate it along with these abnormal movements in between. Huh?
Yes, ma'am.
Okay.
Okay, we can proceed. We have...
Okay, Meet, go ahead.
No, so coming to the movement, one thing is very clear that the patient has a chorea and there is a hemichorea, and chorea is frequently associated with a variety of movement like ethitosis and dystonia. So we say a choreo-dystonic or choreo-ethitoid or choreo-dystonic ethitoid movement. So the phenomenology is predominantly chorea, and if it is one side of the body, it's mostly some structural lesion on the left side. But in India, we see many hemichorea presenting in Sweden hemichorea. And there are rare reports of hemichorea secondary to some vasculitis, like APLA antibodies, and that may have a worsening during pregnancy. So phenomenology wise, it's hemichorea, hemidystonia, but we can just say hemichorea dystonic movements. Coming to the dystonic tremor, like Shweta, you were asking, so if you see the basic fundamental of chorea is a flowing type of movements. So it flows from one body part or one finger to other, and you can see it's very classically flowing. On the contrary, tremor is an oscillatory movement along a joint. So it's certainly not tremor, it's a choreiform movement. So in the interest of time, we can just go to the investigation and imaging if there is any. people can ask their question in the chat box.
Yeah, if any clarifications are there from residents or anyone, we can.
Meet, you can go to the investigations.
We have a
Okay.
talks also, right?
Yes, investigation.
Yes, sir. Coming on to the investigations, hemoglobin was 11 gram %, ESR was 30 millimeter, CRP, ASO titers were negative, serum calcium was 9 milligram per deciliter, thyroid function tests, LFT and KFTs were normal, serum cellular plasmin was also normal, throat swab culture was negative, vasculitic workup was done along with ANA, dsDNA and APLA panel, all were negative. ECG echo and cardiac examination was normal, and slit lamp examination for KF ring was absent. MRI brain was done outside at the time of referral and it was normal. We can see the T1, T2 and flare axial sections in the MRI brain here.
Okay.
What about the vasculitic profile?
Sir, vasculitic profile was also done. It was negative.
ASO titer?
ASO titers were negative, sir.
APLA also?
APLA panel was also negative, sir.
Okay, and what about the echocardiography?
Sir, it was also normal.
Okay.
Very interesting.
So I'll cut it short here, sir. So this was a patient with hemichoria, hemidystonia kind of phenomenology in pregnancy. So yes, we considered mass lesions, vasculitis, Epla syndrome, rheumatic fever, and Sydenham's chorea as the important differentials. But then when all of this was negative, we went through the literature and it has been seen. Actually, Sydenham's chorea is not seen now. So there were earlier studies. There was a paper published in 1986 in JAMA, and they have done it's a vast series of about 220 patients, and they have mentioned that even hemichoria, hemichoria kind of presentation can be seen in chorea gravidarum also. So we do not have the follow-up of this patient, but then telephonically, when we were asked to present this case, we called her up and she said that she has improved. She delivered, and about 3 or 4 weeks after that, the movements had subsided by itself. So this was the case, sir.
Very interesting. Very interesting presentation.
Very nice case.
So we can go to the fourth case.
Dr. Shweta.
Dr. Saurabh?
Yes, ma'am. I'm sharing my screen, ma'am. Is my screen now visible to all?
Yes.
Good evening, everyone. Sorry for the inconvenience. I am Dr. Saurabh, Senior Resident in Department of Neurology, KGMU. I will be presenting a case of 30-year-old female, housewife by occupation, right-handed, married, uneducated, and resident of Gonda, Muslim by religion, and history was given by her husband and is reliable, who presented to us with the chief complaint of decreased sensation on the right half of body, including the face, 1 year back, weakness in right side of the body, 11 months back, and abnormal body movement since last 7 months. Coming to history of presenting illness, she was apparently asymptomatic 1 year back and was performing all her routine activities without any difficulty. She was in 4 weeks of postpartum period, which was a home-based delivery, and it was uneventful when she started noticing that acute onset decreased sensation on right half of the body, including the face, in form of unable to appreciate cold and warm water while cooking and bathing. She also noticed that she felt less pain while pinching her skin on right compared to the left. Following that, her symptoms persisted for the next 15 days, following which she developed sudden onset weakness on right side of the body, along with slurring of speech, for which she was admitted in outside hospital, and some oral medications were started. Following this, her weakness improved over next 1 month. After 3 months of this, she developed acute onset abnormal movement in all 4 limbs, including the head, which was more on the right side compared to the left, which was involuntary, which aggravated with on walking and performing activities. Her voice also became shaky, and sometimes it causes mild communication issues. It was not associated with any abnormal posturing, slowness in activities, and any sudden jerky movement of limb. These movements disappeared during sleep, but did not get relieved with any specific posture or distraction. This movement causes hindrance in her daily activities, and she was not able to perform her fine works. Her symptoms were static for the next 4 months, after which they noticed slight improvement, but there was no change in her quality of daily living. Because of this involuntary movement, patient had developed low mood, decreased interaction with family members, anxiety, and sleep disturbances. There was no history suggestive of any cognitive impairment or memory loss, seizure, myoclonic jerks, visual loss, double vision, abnormal alignment.
Can you show the
Excuse me, ma'am?
patient?
Yeah, ma'am. Yeah, ma'am. The past history, family history, and personal history were non-corroborative. Menstrual history, there was one history of one spontaneous abortion at 8 weeks, and there was one history of one medical termination of pregnancy. I will come to the videos.
So describe the.
So it is this video show the abnormal involuntary rhythmic oscillatory movements which are asymmetrical, more in the right than left, and it also involves the head with yes involvement, involving proximal more than involving proximal more than the distal area with low frequency and high amplitude, resting with postural and intentional component. And I will show the eye movements were normal, sir. This was her speech. It was tremulous speech. When we asked her to walk, her gait was wide-based with normal stride length, with normal pace, without any swing, with normal turn, and she was not able to perform the tandem walk, which is in the next video.
The video is coming very choppy. It's very choppy. I'm not able to see any movement.
I will repeat the video, sir. Just 1 minute.
Voice I could make out, but yeah, video.
Movement we are not able to see. When you share a screen, when you share a screen on the right side, there is a column optimize video. If I can click that optimize, the video will be good.
Or if you have video in separate folders, that also you
No,
can.
this will work. Just optimize.
Screen, share the video.
Otherwise, we will accept what you are saying.
Yeah.
So, in the interest of time, please go ahead.
Yeah, please go ahead.
Now it's there.
Now it is better.
Yes.
Video is now is
Now
video is
please go ahead.
Better.
okay, sir. I will repeat the video.
No, we can. Yeah, we saw. I think you proceed.
Just described in that video only, in which she is walking. Describe all movements which are there. Yes, video.
Okay.
No, just you can show that.
Okay.
Yes, now it is better.
Okay.
You can just show one video, just one video.
Okay, sir. So I will show the video in which she is walking.
No, you are just jumping from one video to other. Just show one video.
Yeah.
Okay, describe these movements.
No, just so. Yes, this video is good. Yes.
These are abnormal involuntary rhythmic oscillatory movements which are asymmetrical, which is more on the right compared to the left, which is involving the head also with an yes movement, involving proximal body parts more than the distal, with a low frequency, high amplitude, resting with postural and intentional components, sir, and which is aggravating with movement and decreasing with rest.
So what are these movements?
Did you check
These
for
are actually
palatal,
tremors and
palatal movements were there?
sir?
Palatal.
No, sir. Palatal tremor was not there.
Okay.
So these are, ma'am, these are actually tremors. It's a hyperkinetic movement, ma'am, mainly a tremor.
What kind of tremor is this?
It is a tremor which is present all on rest position, and it is also having an intentional component. So likely a Holmes tremor, ma'am.
No, did you do a surface EMG?
No, sir, we didn't do a surface EMG in this.
Because to say Holmes tremor, you need to document it. It is less than 5 Hz in frequency.
Okay, sir. Okay, sir.
Because these movements are there on rest, action, and intention. So that is why you are saying it. Okay.
Yes, so you need to do some CMC document. Okay, go ahead.
Coming to the symptom analysis, the first symptom was hemisensory loss, which was acute onset involving the right side of the body, including the face. So I will try to keep my lesion in the cortex, thalamus, or in the mesoddiencephalic area. The second symptom was hemiplegia, which was sudden onset and it was right-sided. I will try to localize it at a cortex, subcortex, or brainstem. And for the tremor, since it was asymmetrical, involving right more than left, along with head and voice involvement, present on rest and increase with posture and intention, involving proximal more than the distal body parts. I will try to localize it at cerebellar outflow tract, midbrain, red nucleus, or basal ganglia. In the axis classification, in the history, axis 1 clinical feature, historical feature, it was adult onset, acute and static, no similar history in past, with no similar history in the family members. The tremor characteristics I have described earlier. Associated signs were history of right hemisensory loss and hemiparesis with no associated systemic illness. In axis 2 etiology, I will try to keep it as an acquired cause, and likely pathology may be demyelinating vasculitis or maybe a metal ion associated disorder. And etiology I will like to keep as NMOSD, MOG, multiple sclerosis, or postpartum osmotic demyelination. Primary CNS for vasculitis, primary CNS vasculitis or systemic vasculitis, and for metabolic Wilson disease. Coming to the summary, 30-year-old female presenting to us with a complaint of recurrent neurological events, including hemisensory loss, hemiparesis, and tremors over a period of 1 year. For anatomical, this I have described, sir, earlier also. So on examination, on general examination, patient was conscious oriented and operative. No such abnormal findings were found in the vitals and.
Tell about the positive things only.
Yes, ma'am.
Tell about the positive things.
Okay, ma'am.
So everything appears.
Okay, ma'am. The positive things only. Everything was normal, ma'am. Other than that abnormal movement, which I have described earlier in the video. Okay. And the cerebellar examination, the intentional tremor was there with a wide-based and impaired tandem walking. Rest other cerebellar signs were normal. And other system examination was also normal.
So we think there maybe a structural thing is there because of asymmetry, because of your localization associated with right hemiparesis, right sensory loss. So there is a possibility of structural lesion there.
Okay, structural.
So do you want to show your MRI? What is there in MRI?
Yes, ma'am. Yes, ma'am. Coming directly to the MRI, then I will describe the routine blood investigation. The MRI shows T2-clear hyperintensity in bilateral midbrain along with mesendencephalic area and also in the periaqueductal area, ma'am. And there was also a hyperintensity, a lesion in the subcortex, in the basal ganglia. These lesions were not taking contrast, and angio was also normal at that time. These images were taken previously when she was admitted outside in some other hospital. Coming to the blood investigation, the CTD and coming to the blood investigation, the ESR and CRP were elevated.
Saurabh, what is the imaging finding? Like there is bilateral midbrain involvement. So is it infarct? Is it demyelination? Is it?
So they were not restricting on DWI. Okay. And it was also not following any vascular territory, sir. So I would first try to keep it as a demyelinating lesion rather than.
So this type of demyelination is usually seen in Behçet's disease, very midbrain involvement.
Yes.
Yes.
That's why we have done all the CTD and vasculitic workup, sir. In the routine investigation, only CRP-ASR was elevated. Other than that, ENA, anti-dsDNA, and other vasculitic profile was negative, sir. We even do a slit lamp examination, which was negative for the KFT, and visual work potential were also normal. The treatment pulse methylprednisolone was given. CSF was done outside, sir, but it was non-corroborative. And we give a short pulse methylprednisolone along with oral prednisolone, and symptomatic treatment with primidone, propranolol, and mirtazapine was given. And she was followed after 1 month. And these are the videos, which is showing she has improved drastically.
So this is favoring more of a demyelination or maybe some vasculitis.
Yes.
Saurabh,
Yes, ma'am.
can you show us the repeat MRI also? So that the
Yes, ma'am.
it's further clear that along with the
Okay.
improvement in her symptoms, the lesions also gradually, I mean, they are less and almost disappeared. So just show it.
I'm just going to the repeat MRI.
This highlights the importance of record keeping and follow videos.
These are the repeat MRI, which shows the lesions. We can appreciate that signal intensity of all the previous lesions has decreased, ma'am, including
The lesions had reduced, almost some of the lesions, they have disappeared, only just periaqueductal changes, periventricular changes, they are there remaining, and the patient also symptomatically improved. So what are the
Have you
learning?
done the NMO-MOG?
So NMO-MOG, she was not could not do it.
affordable.
Paper was available inside with us, so we do.
I have two comments regarding this case. One is regarding the phenomenology. So this type of movements, very similar to the Holmes tremor, can be seen in myorrhythmia also. And if the patient has more cranial involvement, that goes more in favor of myorrhythmia. And if the patient has more limb involvement, that favors more Holmes tremor.
Okay.
Both are slow tremor. Phenomenology wise, looking like a tremor, but we need to do a surface EMG. Second, the etiology looks more like a demyelination or vasculitis. Demyelination, it can be NMO-MOG, and vasculitis, maybe Behçet's is very likely because involvement of the midbrain. So very interesting case because the patient has improved and the lesion has disappeared.
I have also one comment about whenever you see this low frequency, why we are saying Holmes tremor, and Dr. Sanjay pointed out the importance of surface EMG. As you go up, the tremor frequency, the tremor loops which are involved more in the midbrain level, they will have more of the lower frequency. And as on action and this, so are you learning points? Yes, I think here you should highlight that issue. What are the circuits involved, and maybe some comment on that.
Saurabh? Okay. So unique tremor pattern, which Sir was discussing, is I mean, it is present both in rest, action, and intention. It has all three components. As I rightly pointed out, that when the nucleus is more involved, so the frequency is less and tremor is more prominent, and when the tracks are involved, so there is I mean, we have difficulty in differentiating whether it is actually Holmes tremor or the other things are getting involved. So surface EMG is one thing which is important to document the frequency and actually say that this is a Holmes tremor. And it is not a standalone condition. It is actually a syndrome which tells that probably the patient is having some structural lesion in the cerebellar outflow tract. So there must be a structural change which is there. So that we have to look for it, and it of course requires challenges in management. So we have to give drugs to improve tremors, because this patient was very much bothered because of these tremors only. The hemiparesis and hemisensory loss, everything was improved, but this tremor was very bothersome for us. He was a bit depressed because of these tremors. So treatment leads to improvement in these patients. That is
there are two very relevant comment in the chat box. One was the name is not there, it's anonymous. HLA-B51 for your
Behçet's and one is NMO-MOG, yes.
NMO-MOG. So you need to
we could not do, sir, because of poor affordability. We planned it, but patient could not afford it. HLA-B, definitely, that was also a question of affordability. But patient will keep in mind because of midbrain involvement. Yes, we have to discuss it.
One question is, do you see home tremor without structural abnormality? No. Home tremor is basically secondary tremor, and if there is no structural lesion, if the tremor frequency is less than 5, you can see sometime in Parkinsonian tremor, but will not label it as a home tremor. Cascade sign, anybody will like to answer? There is a question related to cascade sign.
Cascade sign. Not sure.
Anybody? This sign is related to the same pathology, and the cascade sign is basically you ask the patient to make a maybe I don't know whether they are asking for the radiological sign or they are asking for the clinical sign, because cascade sign is in many disorders it has been described. Personally, I remember in 2 disorders, but one disorder I can just discuss here is the Behçet's disease. And in the Behçet's disease, the unique pattern of lesion extension from the midbrain to the thalamus on coronal MRI, you can see a cascade sign, and that is very, very considered to be typical. There is another cascade sign which is reported in vasculitis. So I think whoever has been asking, they has been asking about this MRI sign. That is the unique pattern of lesion. And there was a paper in American Academy of Neurology, Annals of Neurology, and they had around 262 patients. And in that paper, it was considered that if the patient has a midbrain involvement, it's very, very typical of a neurobehçet syndrome. So maybe in this patient, we can consider this. So this is a very, very interesting sign. So we are already 6:34.
Yeah, we have crossed the time, but I discussed with Mansi and she told that 15 minutes more we have, so we can go to the talks, and then the question. There's some interesting question is there. Sir, can you explain regarding tremor loops and how to differentiate clinically? So,
this is a very broad question.
Yeah.
So primarily there are 3 tremor loop. One is the cortical basal ganglia loop. Second is the basal ganglia thalamic loop, and third there is a cerebellar influence. So if there is a cerebellar influence, the tremor frequency comes down.
Yes.
And like in home tremor, we see the tremor frequency is down. So any structural lesion where there is involvement of cerebellum and the red nucleus, the tremor frequency is likely to be less. But if there is a basal ganglia involvement of the cortical involvement, the tremor frequency is likely to be high. So this is the basic fundamental loop we should remember.
Correct.
So I think Shweta and Dinkar is going to give a broad view regarding the secondary tremor. This is the plan.
Yes, sir. So we have just 5 minutes each for us, and we'll quickly just.
Yes, so who is going to be the first speaker for this?
Yeah, I will. And
So please go ahead.
can you see my slides, sir?
Yes, we can see.
Okay, so this is mainly some learning for the residents. So secondary movement disorders need to be differentiated from the primary and heterodegenerative disorders. And it is always debated if these movement disorders are really due to the disease itself, as we saw in case 1, or is it an exacerbation of some genetic or environmental predisposition in these patients. Important point is, insult to the onset of movement disorder, the latency is so variable that to have a temporal association in itself becomes difficult in most cases. The commonest secondary movement disorder is dystonia, followed by tremors. So this was one paper from NIMHANS, 103 patients with secondary movement disorders, where drug-induced movement disorders were not included. And as we can see, in Indian context, vascular and infections are the commonest causes of secondary movement disorders. And the most common type of the movement disorders they saw in their patients was dystonia, and dystonia plus syndromes with tremors. So quickly going through 2 or 3 movement disorders. So post-traumatic can be after transient or persistent. There can be transient or persistent movement disorder after trauma. Onset can vary from months to years after injury. And the most important risk factor here is the severity of head injury. So it is more common when the GCS is less than 8, patients have prolonged ICU stay, and the mechanisms can be primary, secondary, and all these movement disorders which have a longer latency are all related to circuits. So it is the alteration of the basal ganglia cortical circuits, the basal ganglia, basal brainstem connections, abnormal plasticity that develops as the patients start showing improvement in their initial clinical manifestations, that these abnormal movements come forth. So this was one patient with diffuse axonal injury who has recovered. About 5-6 years have happened, and now he's having this generalized dystonia. So again, a sustained patterned kind of a abnormal posturing, and the phenomena of overflow where the dystonic posturing or dystonia spreads from one group of muscles to another, and then there's a co-contraction. Whatever has been discussed in the phenomenology of dystonia can be seen here. Then post-stroke movement disorders develop after both ischemic and hemorrhagic stroke with a frequency of 1 to 3%. Again, the latencies are variable. It is usually said that the hyperkinetic disorders, the chorias, bellismus, and regarding hemibellismus, most of us have seen post-stroke or post-metabolic hemibellismus occurring soon after the insult, whereas the hypokinetic takes time to develop. Patient here had a infarct in the posterior putamen, and then he develops this classical, jerky, non-patterned, irregular, non-rhythmic movements, proximal more than distal, so most likely a myoclonus. And then this patient who had gangliocapsular bleed, when he came to us on follow-up after 2 weeks of discharge, he had these movements on the right hand. What we saw in case which Dr. Mead presented, distal movements, but then when we asked him to extend his hands, there is a violent proximal flinging, which has been classically described in bellismus, so probably a chorea bellismus. Then this was one lady I'll just jump through. She had a thalamic infarct. She was thrombolized, was very good for the initial 1 year, and then subsequently she has developed bradykinesia, so probably Parkinsonism. She is not responsive to levodopa. We thought of spasticity also, probably attributing to the stiffness that she perceives on the right hand, but the tone was normal. Reflexes though were brisk on the right side, but she has definite involvement of bradykinesia with both decrement in the amplitude and the velocity of movements when she's performing these alternating tasks in the right hand. And then there are encephalopathic illnesses. This was a lady with Hashimoto's encephalopathy. So what we were discussing in the first case where Dr. Rohit, I was asking him about multifocality of that myoclonus. So again, this is multifocal myoclonus that she was having, and then we gave her steroids, and then she has improved. But the most common secondary movement disorders that are seen in our country, and Dr. Shweta will highlight that, are the post-infective disorders. So Dr. Shweta, I'll quickly go to you.
So is it visible, sir?
Yes, yes.
So I think infection-related movement disorders, they are quite extensive, but I will try to tell a few things. So as Dr. Dinkar said that these movement disorders which we are discussing today, they are secondary movement disorders. So now the axis classification is everywhere we are discussing about axis classification. So residents should know there are 2 axes to define, especially for tremor and dystonia. It has been recommended to define the movement characteristics, and then its etiology. So etiology could be genetic proven, one idiopathic, which is sporadic, or genetic, and then acquired one. So infection related movement disorder or secondary movement disorders, they are acquired ones. which we see. So the secondary movement disorder is a term which has been classified very vaguely actually. So it deals with predominantly trauma, hypoxic brain injury, vascular and infections, and space occupying lesion. And though drug-induced movement disorders, functional movement disorders, and some of the metabolic movement disorders, they are also because of some cause underlying. Still, we don't discuss into secondary movement disorders. At times, they are differently. They are discussed different in a different perspective or in a treatable group of movement disorders. So one is secondary movement disorder, one is treatable movement disorders, in which at times we include all these disorders and some genetic disorders like dopa-responsive dystonia or paroxysmal dyskinesias, which also come into treatable movement disorders. There are some terms which would know that the classification for these secondary movement disorders still need some clarification, whether they will come into a treatable kind of movement disorder, they will be a secondary movement disorders, why we are not including drug-induced and functional movement disorders in a secondary movement disorder. This was one thing. So why we should know this secondary movement disorder or infection-related movement disorder? Because in the area where we are living, so much of infection is so prevalent. So we have a large group of patients who present with infection-related movement disorders. We just need a good clinical acumen, a high index of suspicion to diagnose them. The diagnostic tools are easy for all. It is available. Only few blood investigations, CSF and imaging may tell diagnosis in many of the patients. It is often preventable through vaccination or sanitation, hygiene. It is treatable, and sometimes it may self-resolve. So we can prognosticate the patient that yes, these are the causes for your movements, and maybe you will get better with treatment and everything. So it gives a caregiver satisfaction. And one thing I want to emphasize, that is not about genetics. We are always doing genetics regularly to diagnose our cases. So infection-related movement disorders, we don't do genetics to diagnose them. But yes, I have to say that there is some genetic predisposition in these patients, which always discuss that probably because of this genetic predisposition, these patients, they develop these infection-related movement disorders. So according to that study, which Dr. Dinkar told, almost 20% of secondary movement disorders were because of infections. It could be infectious or post-infectious. A mixture kind of movement can be seen. It could be hyperkinetic, or mixed. Commonly, dystonia, Parkinsonism, chorea, myoclonus, these movement disorders are very common, which we see. Etiology could be infections in the form of viral, bacterial, prion, parasitic, fungal, or post-infectious. So what is the characteristic of these movement disorders when these infections are there? So onset could be at the time of infection, that is concurrent, or there may be a delayed movement disorder, which could present after week or months after this initial insult. Phenomenology could be either mixed, like in Japanese encephalitis, we can see all kind of movement disorders, including Parkinsonism, dystonia, tics, stereotypy. I will show one video. In HIV, we can see if there is a lesion, we can see hemiballismus, chorea, we can see myoclonus, we can see dystonia, Parkinsonism. If predominant axial myoclonus is present, we can see very well in SSPE. Asymmetrical movements can also be seen in rheumatic choreas, as Sir was discussing. So course could be either usually these are related to infection or post-infection, and there is most of the time there is spontaneous remission. Sometimes these movements may even persist for years. So we have to look for the infection markers when we talk about infection. So there may be fever, rash, lymphadenopathy. Like these days, we are having dengue patients, stop typhus patients. Those patients, they don't tend to develop movement disorders. Those patients, they show these signs. Multi-system involvement can be seen in HIV patients who present with various kind of movement disorders. There may be raised inflammatory markers. We can see the meningeal signs in cases of meningoencephalitis. If there is any lesion inside or raised pressure, papilledema can be seen in patients with Japanese encephalitis, dengue encephalitis, and HIV encephalopathy can be observed. Seizures can be seen in SSPE and CC. Along with basal ganglionic involvement, which is causing movement in these patients, we tend to see multi-axial involvement, like brainstem involvement in the form of motor weakness or cranial nerve dysfunction, dysphagia, or we can see involvement of spinal cord in cases of rabies, tetanus. So neuropathy can also be seen. Optic neuritis in SSP patient can be seen. And with Zika virus, there is, of course, developmental delay and microcephaly, which we can observe. Despite all these facts, that these movements are infection related, we tend to see some markers for it, but fever and constitutional symptoms may be absent at times. The evidence of infection may be remote, so we have to be careful and look for it. Immune status may be normal or impaired. CT or imaging at times may be normal, though they tend to be abnormal many times. Travel history, dietary risk factors, they require eliciting and often we miss it. So, and at times movement disorder may be the presenting complaint and other things may be marked. So we can miss those things. So whenever a patient presents with acute or subacute kind of movement disorder, we tend to see the predominant movement which is there. We tend to diagnose a clinical syndrome based on the neurological findings and everything. We tend to rule out functional movement disorders and drugs. And then we come to this infection, para-infection, autoimmune, if there is encephalopathy, fever, behavioral abnormalities and other things. So pathophysiology could be either direct neuroinvasive property of that infective agent, which is causing involvement of the brain parenchyma per se, or it could be because of indirect immune-mediated reaction, which is abnormal movements. So we have 3-step approach. We have to decide the dominant type of movement disorder, its distribution, phenomenology. That is first step 1. Then we see the other features and associated neurological and non-systemic features to make a clinical syndrome, and then we make a differential diagnosis for it. And then we confirm our diagnosis by lab approach. We need to rule out the metabolic abnormalities like hyperglycemia, like parathyroid, calcium, hypothyroid. We have to look for those states. We do microbiology. CSF examination is important to diagnose SSP because the measles antibodies, they are there in CSF if IgG is positive. So that is diagnostic of SSPE. There are various immunological markers in the form of autoantibodies which are there, which diagnose a particular kind of autoimmune disorder. Neuroimaging is often abnormal, so almost 70 to 80% of patients we get neuroabnormality finding. And in the EEG, we can get abnormalities in the form of periodic discharges, short and CJD, short interval and long interval in SSP, which is very pathognomic of these disorders. So this is Parkinsonism patient with who presented with an encephalitic-like illness, and after 3 to 4 weeks of his illness, he developed this Parkinsonian features. He could not move. He has to literally lifted up by his mother. So one physician gave him levodopa. He has drastic improvement with the levodopa, but on the cost of this dyskinesia. So he presented to us with this kind of dyskinesia. He was taking almost 8 to 10 times levodopa tablets daily, and with this dyskinesia, he was doing all. He just modified his doses, started using quite well.
एक बार और बैठो.
So this is another patient. This patient also developed encephalitic like illness in his childhood, and following which he developed this fixed dystonic posturing of his right upper limb, and you can appreciate the dystonia on his right face also, that is fixed, and intermittently with fever or stress or something, this dystonia tend to worsen. This patient also, this disease is static now, but this he developed after an encephalitic illness. This is third patient. We diagnosed her as Japanese encephalitis at our ward almost 6 years back. And she had this generalized dystonia along with behavioral abnormality. And gradually over 3 to 6 months into her illness, her dystonia with drugs gradually decreased. Still, she had abnormal posturing in her right lower limb, right upper limb. And then she developed some coriform movements distally into both of her hands. She had to feed by RT only. After 1.5 years of illness, all this dystonia and coriform movements, they disappeared. Now she developed this vocal tics. These are repetitive movements, vocal tics, and some stereotypic repeated movements which she could partially suppress. Along with these abnormal movements, she also developed some partial Kuber-Bucy-like syndrome, like she had hyperorality, she had inappropriate sexual behavior. This was at around 1.5 to 2 years of illness. When she was walking, she was doing all her activities, she was feeding herself, but these movements were continued. And now she is into her 6 years of illness. She is completely normal. She is walking normally. She is trying to write. She is communicating. So she is greeting her guests. She is behaving normally, except for some irritability and some obsession, which is still there, according to their parents, is persisting. So these three patients which I showed, these are all patients with encephalitis presented movement disorders in different course of time. And the third patient had combination of movements. It started from dystonia, then chorea, then stereotypy tics, vocal tics, motor tics, and then some behavioral abnormalities. And the imaging abnormalities in the first patient who responded drastically to the levodopa, there was significant substantia nigra degeneration on both the sides. And the second patient who presented with a hyperkinetic movement disorder, that was dystonia, he also had the same abnormality in the substantia nigra, but the presentation was different. And the third patient, she has involvement of basal ganglia, involvement of thalamus, and along with mesial temporal area, which on follow-up, these lesions, they gradually disappeared, leading to atrophy. So I just wanted to emphasize that these patients, they tend to develop all kind of movement disorders with a latency, with imaging abnormalities, and they tend to respond with treatment, and over a period of time, they are like maybe lead a normal life. That is what. So when we come to myoclonus, we never forget SSP because it is very prevalent, and all kind of myoclonus, including generalized, jaw opening, eyelid, everything is there. All kind of movement, dystonia, chorea, balism can be seen in SSPE. So this is after measles infection, everyone knows it. After a latency of 2 to 10 years, it develops. Vaccination is the only thing which can prevent the disease. Otherwise, the disease is very fatal, and all these children, they lead a very poor life, and ultimately leading to death. That is very disheartening. So this boy is having a generalized myoclonus here. You can see the characteristic of this myoclonus, that these myoclonus are very slow. So we have to be very vigilant, very slow and very subtle. So we have to be very vigilant when these children, they present with decreased scholastic performance or cognitive decline, on some behavioral abnormality. At times they are presented in psychiatry, they are developing some behavioral abnormalities. And when we see these patients are having this very subtle myoclonic just, this girl, she is having just subtle myoclonus on the right half of her body, hemimyoclonus. This patient, he is a 28-year-old adult. He is having hemidystonia on the left side, along with a subtle myoclonic jerk, which is obvious with a striatal toe. This patient, recently Dr. Ravi published his case with severe dystonic storm in SSP. So this patient is also, he presented with severe dystonia, and with painful spasms in his presentation. So this patient also turned out to be a SSP patient. This young patient, he was doing a job, quite intelligent, and then suddenly he developed this disease, and he had predominantly this eye deviation myoclonus to the right side along with jaw. This young girl, she has been presented with this jaw opening, this jaw opening myoclonus. So I'm seeing this jaw opening myoclonus very commonly in most of the patients. That seems to be a very characteristic thing in SSP. So slow myoclonus and jaw opening myoclonus is one thing which is there in our patients. So like movements, all kind of movements in SSP, all kind of MRI abnormalities in SSP can be seen, starting from the posterior part of posterior subcortical areas to anterior, bilateral, mostly anterior, then involvement of the spons, MCP.
We have a few minutes.
Yes,
few minutes.
And this atrophy. Yes, sir. So periodic complexes, they are diagnostic of this thing. This patient is having NCC, neurocysticercosis, on the right thalmocapsular lesion presenting with chorea. This patient is of tuberculous meningitis. He was started on ATT. He developed hydrocephalus during the course of his illness. And when shunt was placed, he developed these abnormal tremulous movements, predominantly proximally, possibly because in follow-up CT, he developed infarcts, multiple infarcts, maybe because of shunt injury or because of these infarcts, he developed this. So prion disease, very subtle focal myoclonus, multifocal myoclonus can be seen, like in this patient. He progressed very rapidly within 15 days of his admission. He's having multifocal myoclonus involving right upper limb, left upper limb, and right lower limb. The MRI and EEG, they are characteristic ribboning in the cortical areas along with thalamic and basal ganglionic, along with caudate and putamen involvement, and this 1 per second discharges. So some of the post-infectious movement disorders, synonym chorea is very common in our setup. So this patient is chorea, brain chorea, involving chorea over the face, the limbs. She was so hypotonic that she could not move her limbs, she could not move her body. This takes the say chorea mollis. This is severe weakness because of chorea and hypotonia. And this is the follow of the patient, which is normal and is normal. So this is one more disorder, post-infectious opsoclonus myoclonus ataxia syndrome, likely to be post-infection after viral infection or something. But in children especially, residents should know that neuroblastoma has to be ruled out before sending them back. So treatment often preventable by vaccination, like for SSP, sanitation has high and hygiene has definitely reduced the burden of neurocystic sarcosis in our area. Now we see less of these patients. Antiviral, antitubercular treatment, and antiparasitic as the treatment options for those infections. Steroid and immunoglobulins may be given for autoimmune encephalopathy or other conditions which don't respond to normal treatment, supportive treatment. Thank you, sir.
It was a very good presentation by Dinkar and Sweta, and I really enjoyed their presentation with so many videos and so many cases, and very learning cases. Really, I congratulate both of you for having such a interesting collection of cases. And in the interest of time, we will just answer some of the questions in the chat box, and then we'll wind up. So what makes a person to have post-stroke Parkinsonism versus other hyperkinetic disorder? So post-stroke Parkinsonism, now the definition is if there is a nigral involvement, if the person has Parkinsonism, we say post-stroke Parkinsonism. Propriospinal we have already discussed. For patient with dystonic storm, was autoimmune profile done? I don't know whether
so we tend to do this autoimmune profile in every patient of SSP. Despite being IgG positive, we tend to do all autoimmune panel and all treatable things, including KF ring and autoimmune thing, so that we don't miss anything. But positivity of IgG in CSF, that is diagnostic of, and EG. So that is the point which.
So I will just say that you should definitely write up these cases, very nice cases. And I will hand over to Dr. Ravi to wind up today's proceedings.
Yeah, I think as Dr. Sanjay pointed out, Dr. Shweta and team from KGMU and Dr. Dinkar and team from RML Lucknow have done a very wonderful job, and they have that kind of cases and spectrum. I don't think this was a great learning opportunity to those who attended. And I congratulate them again for this presentation also at the end.
And attendance was also good. It was more
Yes.
than 100 most of the time.
Still 69 people are there. So we crossed over by half an hour almost, but I did not stop because this is actually the case, and then the approach, complete, presentation from the clinician's perspective. And that is what Indian Academy of Neurology wants the people to understand, and PGs to understand, that movement disorders are, the approach is most important. Defining the phenomenology is most important. And it has been completely rightly pointed out by all the speakers and the residents. So I again thank everyone who joined together, and Dr. Sanjay for being here again as a chairperson. Although the president and I think secretary couldn't join, but I will convey them the best wishes. Okay, so we can close down. Thank you so much.
Thank you, sir. Thank you.
Thank you.
Bye.
Bye, bye, sir.